Welcome to your Aged Care Compass podcast. Join us to find out how to support your older loved ones at home. We're going to help you make sense of Australia's aged care system. We talk about legal and financial considerations for ageing and how chronic health conditions impact your older loved ones' well-being. And we share real-life stories of where it went wrong for people and how we got them back on track.
Welcome to today's episode, everyone. Today's topic has been a much requested one from our followers. In fact, we've had a lot of requests about topics related to dementia. So we're setting the scene today with a discussion on what dementia is and how it's diagnosed. I'm joined by Brisbane psychiatrist and author Dr Kailas Roberts. Kailas is a psychiatrist with a particular interest in brain health and dementia, and he's the author of Mind Your Brain, the Essential Australian Guide to Dementia. He's been working as a doctor for over 20 years and has more than 10 years' experience in assessing and treating patients with cognitive difficulties. Kailas runs a busy private practice and memory clinic in Western Brisbane and consults at a number of local nursing homes. Kailas, we still see people confused about what dementia is. We hear people saying, "Mum has Alzheimer's disease, but not dementia." Or we hear people saying memory problems related to getting old. Could you explain to our listeners what dementia is?
Thank you, Coral. And thanks very much for having me on in the first place. It's obviously an important topic that we're going to be discussing this morning. So yes, there is a lot of confusion about what we mean by dementia and Alzheimer's disease and things. And I frequently have people come to my clinic asking me about this and seem quite confused. So it's very good to sort of try and understand what we mean by these terms. So really, when we're talking about somebody having dementia, we're actually not describing what the cause of it is. And I'll come on to that in a moment. But really, all dementia means is that you have some kind of problem with your cognition, which is another word for thinking. And that's often memory, but it can be other things as well. So language ability or problem solving and so on. Even changes in behavior sometimes are seen as a cognitive sort of skill. And so dementia really is just some syndrome where you have an impairment of memory or some other cognitive skill that is sufficient to cause some impairment of daily function. That means that you cannot navigate day-to-day life in an efficient way that you used to be able to. So even with the use of sort of compensatory strategies such as diaries and calendars and so on. So that's really all dementia actually means. So it's an umbrella term, and under that sort of umbrella, if you like, there's many, many different causes of dementia. There's a few which are the major causes of dementia, but there are actually about probably 200 different causes. But dementia, really all that means is cognitive impairment of some description enough to cause impairment of sort of day-to-day function.
Wow, okay. And is there such a thing as age-related memory decline?
There is, and sometimes it can be a little bit tricky to differentiate between just the effects of normal aging and the very early stages of something that's more progressive and sinister, I suppose. But ultimately, as our brains age, we do have changes in both the structure and function of our brains, and that then leads to certain symptoms developing. So we know that as we get older, for instance, our hippocampus, which is a really sort of important small part of our medial temporal lobe, tends to shrink. And that's really instrumental in allowing us to sort of memorize things and take in new information, absorb it properly and encoding memories. And so the shrinkage of that actually means that as we get older, our efficiency at actually remembering things is somewhat compromised, but certainly not to the same degree as somebody with dementia might have. Mm-hmm. And then we also have other changes such as sort of shrinkage of the front part of the brain, which then leads to sometimes other issues such as the speed of retrieval of memories, for instance. So it's just slower to kind of bring things to mind, and also impacts on things like attention, which is influenced by the front part of the brain, so less able to perhaps focus or even shift focus sometimes, and less able to problem solved to a degree as well. So there definitely are some age-related changes that they do tend to vary an awful lot, I would say, and that's certainly been my experience. So some people age really well cognitively and other people not so well, and there could be all sorts of things, and perhaps talk about some of those things, but all sorts of things that influence that. But we certainly do see something that I suppose is just age-related cognitive decline, which we wouldn't necessarily say is a disease process per se. It's just part of the aging process, but it is quite distinct from forms of dementia and other issues that affect your brain.
Okay, that's an excellent explanation of that. So you just mentioned there are around 200 diseases, is that correct, that sit under that dementia umbrella? But there are like 4 big ones, aren't there, that people are probably more familiar with. Could you describe for our listeners what those more familiar disease processes are that fall under that umbrella of dementia?
Yeah, sure. So, well, Alzheimer's disease is the most common, and that accounts for probably about 2/3 of cases of dementia. Then you have vascular dementia, which is a form of dementia caused by impairment of blood supply to the brain. Then you have a thing called frontotemporal dementia, which affects the frontal or the temporal lobes of the brain, or sometimes both. And then there's I guess, 2 syndromes which are similar in terms of what the underlying disease is, the proteins deposited in the brain. So one's called Lewy body dementia, and then there's Parkinson's disease dementia as well. So they're kind of closely related. So Alzheimer's disease, vascular dementia, frontotemporal dementia, and Lewy body or Parkinson's disease dementia, they're the big ones. And they all present in different fashions to a degree. I think it's also important and quite interesting to point out that actually it's unusual for people to have just a single problem causing their dementia, particularly as they get older. So if you develop dementia in your 80s, there's a good chance that you might have more than one thing causing it. And there was a study on many, many thousands of people in the UK that showed that people that have been diagnosed with Alzheimer's disease clinically during their lifetime, when they passed away and they looked at their brains under the microscope, they actually found that 80% of them had more than one thing going on, whether that be Alzheimer's disease and vascular disease, or Alzheimer's disease and Lewy body disease. So often it is multiple things that are causing dementia. But yeah, certainly I would say that sort of combination of Alzheimer's disease and vascular disease probably accounts for the majority of the issues.
Yeah, and in fact, that's what my dad had. He was initially diagnosed with Alzheimer's disease, but he had the cardiovascular risk factors, and I talk about all those strokes that he had as well, and he did end up having vascular dementia as well. Just wondering if you could provide a little bit. I know this is like one of those questions, like how long is a piece of string? We could probably talk about this for a whole hour or more. But if a person with those 4 disease processes that you just mentioned, how do they differ? Like if someone might be progressing towards a diagnosis of Alzheimer's disease, and then someone else might be developing a Lewy body dementia, how do they look different?
Yeah, it's a good question. And there is, as I say, a degree of overlap, but there are also some distinct features. So Alzheimer's disease, the typical sort of first presenting symptom is sort of rapid forgetting, essentially. So memory loss, the inability to form new memories. So that might present day to day as somebody being quite repetitive or forgetting what you've told them in conversation. They might be disoriented in time because their memory does not allow them to know what day of the week it is and things, and so they lose that sort of orientation anchor, if you like. So that rapid forgetting, misplacing objects, missing appointments, events, and things like that. So that's probably what most people think of when they think of dementia, is that sort of just inability to remember the more recent memories. And interestingly, and I think this is also something that's quite good to point out, that long-term memories, so memories from many, many years ago, at least in the early stages of Alzheimer's, are generally pretty robust. They're still fairly intact. And so people often come to me and they say, well, I can't have Alzheimer's or I can't have dementia because I can remember everything back to my childhood. And there's a reason for that. And the reason really is that the memories from many, many years ago are already sort of firmly embedded in our brain, whereas the new memory, so something new that we experience, it needs to go through that hippocampus structure that I was talking about before and to be properly sort of encoded and then embedded in the brain. Now, in Alzheimer's disease, you have a particular shrinkage of that area so the hippocampus just doesn't work as well. So anything new doesn't get properly encoded by the hippocampus, and so therefore it's not embedded in the brain. Old memories don't require the hippocampus so much to pull them out. So people often remember things from many, many years ago, but they cannot remember what they had for breakfast or what they did yesterday and so on.
Yeah.
So that's, I suppose, the typical Alzheimer's profile. As the disease sort of progresses, you then do have other cognitive sort of functions impacted, such as your spatial skills and language and so on. But early on, it is typically the sort of the memory side of things. Vascular dementia also can affect memory. I mean, to an extent, it depends where the vascular disease is. So if you have a sort of big stroke that sort of affects one part of your brain, which is responsible for a certain cognitive function, obviously that's going to be one of the main areas that's affected. But you can also just get what we call sort of small vessel disease, where it's rather diffuse. It's in much of the brain. And so you can certainly have memory problems with vascular dementia as well. But one of the things that helps us differentiate to a degree is that if somebody's forgotten something and they have vascular dementia, they're more able to remember it once you give them a bit of a clue about it. So So it's a retrieval problem. So the information has gone in, it's just harder to pull out. Whereas if somebody has Alzheimer's disease, because the hippocampus is faulty, the information hasn't gone in at all, however much of a clue you might give about things, the information's not there. There's no memory of it. So actually prompting somebody or giving them a clue and knowing whether they're actually then remembering what they've forgotten, and it gives a bit of an idea what might be going on diagnostically. So there still are memory problems, but they're slightly different in vascular and Alzheimer's disease. I think the other thing about vascular disease, I mean, you might have some other signs of strokes, of course. You might have your weakness, sensory changes and so on. You often get emotional changes as well. So people can get things like depression, anxiety, and so on. That's more common at least in the early stages of vascular dementia compared to Alzheimer's dementia as well. And you can get sort of changes in sort of movement and sort of general slowing and things as well with vascular dementia. So that mood component is possibly a bit more prominent in vascular dementia than Alzheimer's early on.
Okay.
Frontotemporal dementia, so that really depends on whether it is predominantly the front part of the brain, the frontal lobe, or the temporal lobe being affected. So if it's the front part of the brain, that's responsible for a lot of our sort of behavioral manifestations, if you like. So our frontal lobe allows us normally to kind of inhibit impulses and to act in a socially appropriate manner, not to be sort of overly reactive to things. It also allows us to be sort of empathic and know what other people's emotional states are and read social situations. And so if you have sort of a frontal variation of frontotemporal dementia, often what we see early on is a behavioral change. So somebody might be less empathic, or they might be apathetic, they're not motivated to do anything. They might be disinhibited, saying inappropriate things in public, that sort of thing. So you get these behavioral changes early on, and they can precede any sort of obvious other cognitive problems. If it's a temporal variant of frontotemporal dementia, then it tends to be more language initially. So you might find that people are just struggling to find the right word and not able to communicate verbally as well as they would. So there's a bit of a difference depending on which part of the brain is affected in frontotemporal dementia. And then the fourth duo, if you like, the Lewy body and Parkinson's disease. So they present a little bit differently to each other, although, as I say, there's an overlap. So there's a protein called alpha-synuclein, which is responsible for both of those conditions. But it really depends where that is in the brain as to whether you're more likely to have Parkinson's disease dementia or Lewy body dementia. So Parkinson's disease dementia is where the proteins often sort of get embedded sort of deep in the brain, and that controls movement and things. So often you'll see people with that typical Parkinson's type motor changes. So they might be slow and stiff and stooped and might have a tremor and things like that. And that's an early sign as well. And then they might go on to develop cognitive problems, which are often sort of just a slowing of processing and retrieval problems again. Lewy body dementia, you might get some of those changes in movement early on, but often they come a bit later. And Lewy body dementia actually really is quite, if you see somebody with Lewy body dementia, is really quite distinctive if it's a classic syndrome, because often what they have are these really marked fluctuations in their level of alertness and also their cognitive function. So, one moment they might seem reasonably lucid and okay to converse, and then the next moment they might appear as if they're kind of sleepy and they're just very confused. And that can happen, multiple times within a day. So that's a really sort of hallmark feature of Lewy body dementia. And then they can have other things as well. So you might have visual hallucinations, which are really often very detailed. And interestingly, you can get these things called Lilliputian hallucinations. So you may have heard of Gulliver's Travels, and Lilliput was where everybody was very, very small. And so Lewy body dementia often see very small animals, people, improbably small, sort of running around and things in their room. So it's a really kind of distinctive syndrome that you get. And then in both of those conditions, Lewy body and Parkinson's, you can have problems with sort of blood pressure and the falls and so on as well. So, yeah, I suppose that's an overview of the different symptoms. So they are quite distinctive, but there's also some overlap between them as well.
Yeah, that is absolutely fascinating, Kailas. You've given me, I'm going to go and research some of these things that you've just discussed right now. So look, there are health conditions that can look like an emerging cognitive impairment too. What would these conditions be?
Yeah, so that's obviously a really important thing to try and understand. Is there something reversible going on that's causing the cognitive problems? And because we don't, obviously, dementia is a progressive condition, and unfortunately at the moment it's not curable. So you really don't want to jump into the diagnosis before you're absolutely sure that that's what's happening as opposed to something else. So there are a number of things that you sort of need to exclude before you, I guess, come to a decision about dementia being present. And broadly speaking, I suppose I look at them in terms of medical conditions and then psychological conditions and then sort of medication effects as well. So amongst the medical conditions, there are certain deficiencies of things that can actually cause really significant cognitive impairment. So things like vitamin B12 and folate, if you don't have enough of that in your system, then that can cause cognitive problems. The other one classically is vitamin D. So we live in a country where everybody, of course, is understandably obsessed about getting skin cancers. And so we actually, unfortunately, although skin cancer rates are going down, vitamin D deficiency is going up because people are very worried about the sun and, being exposed to too much. So vitamin D deficiency is another well-known cause of, cognitive problems that needs to be picked up. Then anything that sort of affects various organs in the system can actually also cause cognitive impairment. So if you have problems with your liver, which are severe enough, or problems with your kidneys, or problems with your thyroid gland, for instance, all of these things might cause issues from a cognitive perspective. And these things can be easily picked up on blood tests. And then the other thing, I suppose, from a medical condition perspective would be sleep apnea. So sleep apnea is this condition which is actually very, very common, where the apnea just is a word that means to stop breathing. And really the classic symptom is that when people are asleep in bed overnight, they have these periods of stopping breathing, which might last, 10, 15 seconds or more, and it wakes them up from sleep. And so they're getting problems with both oxygenation. We can see from monitoring people's oxygen when they're having these periods of apnea that their oxygen levels go down, and you need oxygen for a fully functioning brain, of course. And then they're not getting deep sleep either, and deep sleep's really good for your brain in the long term. So sleep apnea is something that's really important to pick up. Often it's, of course, the bed partner that will notice these periods of not breathing. Sometimes that's not the obvious thing, and the obvious thing is really loud snoring. And the other thing would be profound sort of tiredness during the day. So that's the other sort of key symptom. Sometimes people wake up with headaches, or they wake up choking and gagging and things. So there's a number of different symptoms you can get. But again, it's reasonably easily diagnosed. You have a sleep study, and there are treatments in the form of masks and splints and things that you can wear, which are really effective, and definitely would recommend having that sort of looked at if that's a problem. And sleep apnea, I mean, as well as causing acute problems with brain function and memory and so on, if you don't treat it, and particularly if it's sort of severe over a long period of time, does increase your risk of developing dementia, more permanent damage sort of later down the track.
Mm-hmm.
So those are probably the big things. Certain things like diabetes, acute changes of blood sugar can affect cognitive function as well. And also diabetes untreated over the long term can increase your risk of dementia. So that's another really important thing to pick up. But those are probably the main medical conditions. There are acute things. People obviously can have a stroke and not necessarily develop dementia as a consequence of it. People can have a head injury. People can develop this thing called normal pressure hydrocephalus, where you get fluid buildup in your ventricles, which are the sort of sacs in the brain, and that can cause its own problems. And again, that's treatable with a shunt to get rid of some of the fluid. But there's lots and lots of different medical conditions. Those are probably, I guess, the more common ones. Medications wise, so as people get older, obviously they end up on considerably more and more medications, and often it's not a particular medication that's the problem. It's lots of different medications being used at once, each of which have a little effect, but cumulatively they're a real problem. So when you're on lots of different medications, you really need to be careful about considering the effects of those on brain health. But there are certain medications which are not good for brain function. So one of them are the opiate-based painkillers, so really strong painkillers. So there's things like codeine, endone, Targin, some of these patches, fentanyl patches, Norspam patches and things. So they can certainly impact cognitive function. And I've often seen this, particularly in people in nursing homes, actually, where there's clearly some pain there, and understandably they're treated for it, and their cognition really drops off and they become a lot more confused on these medications. Then there are certain psychiatric medications, so things like Valium, temazepam, alapam, oxazepam, those sort of things are things that help us relax and help us sleep, which are very useful medications in the short term, but over the long term can really be problematic, and they can certainly sort of impair our memory as well. And then there are things that affect what we call our cholinergic system, which is one of the neurotransmitter systems in the brain that allows us to learn and memorize things, and certain medications interfere with that. So things like some of the bladder medications for incontinence, things like digoxin, warfarin, lithium, lots of the commonly used medications can have a small anticholinergic effect. And again, if you have enough of them, then that can be a problem for the brain. So these are all things that need to be kind of looked at. And then thirdly, I suppose the psychological condition. So it has been often the case that I've seen people whose cognition has not necessarily, the decline's not necessarily being caused primarily by depression or anxiety, but it's certainly a lot worse because of it. I have occasionally seen people who their presumed dementia is actually simply down to depression. I remember a chap a few years ago who was in a nursing home who'd actually been diagnosed with Lewy body dementia, and I saw him and he was clearly very depressed. And in fact, we sent him to hospital. He had ECT and he fully recovered. So no cognitive problems. So, that's rare to see that. But, when you do, obviously, it's very gratifying and really important to pick up. So depression and anxiety and even other conditions like PTSD, ADHD and things, they can cause lots of cognitive problems, and in the short and the long term.
Fantastic. My goodness. What wonderful information. So, look, Kailas, if a person presented as being increasingly forgetful, less willing to engage socially, and seemed to be not enjoying the things that they previously did, and a family member was concerned, what would be the next step in getting to the bottom of why these changes have occurred in their older loved one? What would they do next?
Yeah, it's an interesting question. So I think, very much depends on those particular circumstances. I would always try to have a conversation with the person. Now, sometimes that goes well, sometimes it doesn't, as I'm sure you're aware. Unfortunately, if it is a dementia process or the early stages of that might be occurring, there is a part of the dementia sometimes is a loss of awareness of the problems. So sometimes the insight to the issues is not there. And so then if you start talking to them about your concerns about their memory and so on, they might get quite defensive or, so they can sort of shut you down or minimize things. So that's tricky. But I do think you always really need to kind of have that initial conversation and just get a sense of how aware the person is of what problems there might be and, how open they are to having it sort of evaluated further. Now, the hope is, of course, that they will agree to a further evaluation. And really, at that stage, I think the first point of call would probably be the GP.
Yeah.
Because the GP often knows the patient well for a start. So that's really helpful to sort of get an understanding from their perspective about what might have changed. And the GP can also do a lot of sort of screening tests, if you like, again, coming back to some of those reversible things, like maybe even, actually, I didn't even mention the medical conditions, but things like infections, they can have some sort of infection you may not be aware of, a urinary tract infection sometimes can even be enough to cause problems with your brain. So if you see a GP, then they will hopefully do some sort of initial screening tests, generally blood tests and urine tests and so on, and get a bit of a sense of, what might be sort of causing these issues. And when you're talking about people sort of socially withdrawing and so on, obviously you need to worry about depression and anxiety as well. So there's that whole conversation around, well, what's going on in their lives at that particular point in time? Are there particular stresses? And just sort of ruling out or treating those mood disorders. So yeah, I think that the first steps really are to have that conversation with the person, but acknowledge that may or may not go as planned, as well as it can be. Hopefully, if you can get the person on side, then getting them to their GP for that sort of initial evaluation is a really good thing. If they haven't agreed to having any evaluation, of course, that makes things very tricky. And I think all you can do is sort of just hang in there as a sort of latent support and just sort of revisit it from time to time. You might be able to have other relatives speak to the person. There's nothing stopping you really phoning their GP and actually telling your concerns. You may not, they won't be able to discuss that person with you, but you're allowed to just mention these things. So then when the person goes to see the GP, maybe that can then open that sort of conversation and so on. So those are the very first steps, I would think.
FlexiCare is a not-for-profit organisation which supports older people living in Brisbane's southern suburbs to live their best lives in their own homes and communities. FlexiCare don't have grand plans to be the biggest aged care provider. They want to be known for treating each one of their participants as an individual who they get to know well. They answer their phone calls personally when clients ring them. They give their clients easy access to a home care partner who can work with them to deliver the best mix of support possible. If you're in Brisbane South and want to know more, give their friendly team a call on 07 3422 8400 or check out their website, flexi.org.au.
Yeah, excellent. So look, we've just touched on seeing a GP and how a diagnostic pathway might begin. But leading on from that, what are the other steps that perhaps a GP or a specialist like yourself might look into if you were thinking there's something here that requires further investigation? What are the kind of tests that someone like yourself that specialises in dementia, what do you do for your patients?
There's different parts to it, and I might just sort of explain my approach in the clinic, which I think is probably fairly similar to most specialists. But there's sort of first assessment, if you like, when you're actually just getting to know somebody, and really that for me would generally takes around about an hour, and we don't tend to do too much in the way of the actual objective cognitive testing in that first assessment, in part because it can be quite confronting.
Yeah.
And so it's just a matter of actually trying to get to know the person, understand what issues they have, understanding what how much insight there might be, and just sort of getting a general sense of them as a person. It's really important if you are trying to have somebody assess that you're worried about their memory. It's really important that you can to be there yourself as an informant, because obviously inside issue and for other reasons. We all have different perspectives on things. Sometimes I've seen people by themselves who have memory problems, and I don't have anybody else to kind of ask their thoughts on it, and I'm just not getting the whole picture. So I think more than one person is really important. So in that first assessment, we go through the history and we do some examination, and then after that, if there does appear to be some sort of issue, then in the clinic at least, I would ask my OT to do some cognitive testing as a separate session. So they come back at a later stage and they have certain, I guess, tests that are standardized and well known, and we know what the normal values are and what represent a problem. So they get those tests done, and that will help us identify which different parts of the brain are functioning and not. And then at the same time, between my first appointment and my second appointment, we get that cognitive testing done. We also often get more blood tests done because the GPs do the basic blood tests, but I quite like to do a sort of fairly broad range of blood tests, which just to make sure nothing else is going on. And then the third part of the puzzle really is the neuroimaging, so that scans. And I mean, you can theoretically diagnose forms of dementia without a brain scan, and that's what they used to do, many years ago. We have reasonably ready access to certainly to CT scans, also to MRIs in bigger centres as well. And I really like to have people have MRIs if they can. So these are these brain scans, which they give a very good resolution of the brain. They can tell us a lot about the structure of the brain, whether there are areas of shrinkage, whether there are things like tumours in the brain, which is unusual, or bleeds and things. But they can also show there's areas of shrinkage, like in the hippocampus I was mentioning, or the front part of the brain. And they can also show in quite good detail vascular disease as well. So they give us a really good sense of kind of what's going on. So that's kind of the sequence. So I see them, they go away for cognitive testing, they get some more blood tests done, they have some further scans done, and then we meet up again, generally around about the 6-week mark, and we go through all the information we have, and we say, well, we have our answer or we don't. And sometimes it is the case that we don't have our answer, because the scans are they only have a certain sensitivity, or some people in the very early stages might do quite well on their testing and so on, but you still think that there's a problem. And then there are other things that you can then go on to do. So there's another scan called an FDG PET scan, which is basically just a sugar uptake scan that looks at activity in the brain. So that's an option for people, and that's maybe even a bit more sensitive than the MRI. So sometimes we do that. These days, you can even get what we call an amyloid scan done. So amyloid is the protein that's in the pathway to Alzheimer's disease. It's amyloid and tau that build up in the brain that cause the issue. And the amyloid scan shows how much amyloid is in your brain. So it's a really sensitive test, and it basically says, is this Alzheimer's or not? It doesn't tell you what other dementias, whether they're maybe present or otherwise, but it's very helpful from a sort of Alzheimer's perspective. Unfortunately, at the moment, it's quite expensive. In Brisbane here, it's about $1,600 to get that done, so it's not cheap, but can be very helpful. There are some blood tests available, which are about the same cost at the moment, but likely to come down a lot, which can also pick up the presence of certain proteins in your blood, which then mimic what's in your cerebrospinal fluid in your brain. And so they, I think, will be really helpful for us going forward. And then sometimes I get the neuropsychologist to see the person. So again, if you've got somebody in the very early stages, they're very highly functioning. I've seen academics, lawyers, doctors, and so on, and they know there's something wrong, but they pass the OT cognitive testing really easily because, they're very educated, highly intelligent people, but we know there's something not right. So then we do sometimes get a neuropsychologist to see them, and the neuropsychologist then does a very in-depth cognitive testing, lasts about 4 hours or so, and gives us the best detail and best data we can get on different cognitive function. Unfortunately, and quite wrongly, I believe, Medicare don't subsidise the neuropsychology assessment, so they also tend to be quite expensive, around about $1,500 as a minimum. So we don't jump in and do these more expensive tests to begin with. We only do them if we kind of need to, but they're definitely available. And the other thing you can do, just the, set of completeness of the conversation, I don't personally do it, but I would refer to a neurologist if we needed to do it, but you can have a lumbar puncture done, so a spinal tap. And that also can pick up the proteins in your spinal fluid, which may suggest strongly that you have Alzheimer's or otherwise. So there's lots of things that we can do, but you just approach things bit by bit till you get your answer. Sometimes, even despite doing these things, we actually don't have the answer anyway. And then what we have to do is we just really wait and see sometimes. So that's what you can do. And so you might review them. I have a number of patients who come back to me annually, for instance. And so you can see that things are declining a little bit, but not a huge amount. And then you might do scans every year, or you might repeat the cognitive testing every year. And with time, sometimes you get your answer. Sometimes we don't know what's happened. Somebody might present the first time as having some memory problems, and we see them a year later, nothing's really changed, but they're better. And we think, well, I'm not sure what that was, but it's good. It's obviously not suggestive of a dementia, which is progressive. So that's the general approach I suppose I take in terms of the diagnostic pathway in my clinic. And most people would do something similar, I think.
Yeah. So look, you said that it could take 6 weeks for you to reach a diagnosis. Correct me if I didn't interpret that correctly, but in the space that I used to work in, which was the public health system, the geriatricians I used to work with took, like about 6 months until they came to that diagnosis. Now, that may have been the public health system, but if you're able to arrive at a diagnosis for some people in 6 weeks, is that because you work within a clinic that has all those wonderful allied health clinicians there, that you can get that additional investigation done in that time frame? Would you attribute that 6-week time frame to having all those fantastic resources, those people working with you, or not?
To a degree. So certainly the neuropsychology is probably a bit more accessible where I work in the private system. I think in the public system, the issue is that you just wait a long time to have things done. And often actually the rate limiting step might be the brain scans, for instance. So the private system, we can get the brain scans done within a matter of weeks. And so the 6-week kind of period is just sort of allowing a bit of wriggle room to get those scans done. They're normally the rate limiting step. In the public system, there's no particular reason you couldn't get, I suppose, the more basic cognitive testing done quite quickly. I do think, although I'm keen to try and find the answer sooner rather than later, sometimes there is actually a little bit of value waiting a while to see what transpires over a longer period, because, as I say, people can go through periods in their life when things aren't quite right. But if you have a kind of a whole 6 months of observation, you really get a clearer sense. And some people might argue that 6 weeks is not a huge amount of time. But as I say, often at that 6-week mark, we don't really have our answer necessarily. It's just that if everything kind of lines up, we have the cognitive testing and the brain scan, it all looks like Alzheimer's disease, then I think we need to call it that and get on and do what we can to move forward, because the waiting is obviously a real concern and very anxiety inducing for people not knowing what's going on. And although some form of dementia is not a diagnosis anybody wants, at least once you have it, you can form a plan, you can work out what the next steps are. If you don't have any sort of sense of what's causing things, you're just in limbo, and that's quite distressing.
Yeah. So when a person initially receives their diagnosis, what do you think should happen next? What should be the next steps?
So there's a lot of work around education, and I'm very well aware that when I give we'll have that second appointment after we've got all the information together, and I'm telling somebody they have some form of dementia, that a lot of the information won't go in because of the stress of the situation. But I do my best to sort of try and explain what's going on, explain what the cause of things are, give an idea about how things might evolve in terms of the progression of the disease and what you can anticipate. But as I say, only a little bit of that information goes in. And so I'm very keen to give people information or links and written information that they can take home with them, so they can have a look at all these things when they've perhaps got a bit more time to sort of process it and it's not quite so confronting. So I'll often give them information from Dementia Australia, for instance, or there's another one, This Way Forward, who are a good organisation. So depending on what the form of dementia is, there's lots of different resources out there, of course. So we have that, I guess, the conversation around education and just making sure they know what's ahead as best we can. We do have, I'm blessed really in the clinic to have a care navigator. So what I'm trying increasingly to do is after the person sees me and they receive a diagnosis, I try and get them followed up by a care navigator sort of a few weeks after their initial appointment with me. And the role of the care navigator is, again, just to sort of identify all the different issues that might be going on, but also to touch base and to answer, because she's very skilled, Leah, to answer all these kind of questions around, again, what dementia might involve and what might need to be addressed. So I think that ongoing support is critical. And that's perhaps a little bit what's different about our clinic, is that we do offer that sort of post-diagnostic support. I think the public memory clinics are great diagnostically, but they just don't have the capacity to offer supports afterwards. So once somebody receives a diagnosis, you then sort of have to try and identify what their immediate and then ongoing needs might be. And that will obviously depend on their own circumstances, the severity of the dementia and so on. Some people are in the very, very early stages and we don't necessarily need to immediately increase supports, but I would always recommend that they, for instance, register with My Aged Care to start that ball rolling. You would know even more than me, Coral, how much of a difficult situation that is with My Aged Care, how long the process is, how involved it all is. So that's a really important thing to sort of just try and encourage people to do, even if they're, fundamentally well and coping okay. But some other people, there may be a more immediate need for support, and then we just try and help people get those in place. And that might be of a practical nature, so making changes to their house, which would possibly be something an OT that would be involved with and be able to sort of help out with. We might get physiotherapists involved to sort of help improve mobility and promote exercise, which is still very important regardless whatever stage of dementia you're in, and to improve mobility, stopping the risk of hip injuries and things like that as well. We have a clinical psychologist, and often either the person with dementia or their family member may, of course, have difficulties adjusting to the diagnosis, and it can cause states of clinical depression and very significant anxiety in people. And so I think offering emotional support as well as practical support to both the person with the condition, but also their family members is really critical as well. So it really kind of depends on the individual needs of the person. But yeah, as I say, I'm kind of blessed to have all these people around me that can offer support as time goes on and depending on what happens with that individual with the dementia.
Yeah, I think it's a wonderful service. I think the way you set up your clinic, Kailas, is, I would say it's like the benchmark. It's the gold standard. It's just, I think I mentioned earlier, my background is MDT, multidisciplinary teams as well. And I certainly love to work with, my colleagues, allied health practitioners, occupational therapists and physiotherapists, because I can see the benefit that they bring to the care and support of an older person if they do have a dementia or they don't. So I think it's fantastic the way you approach the care of your patients.
Thanks. Yeah. And look, to be quite honest with you, I think my colleagues in the clinic are probably more important than I am post-diagnostically. Really, I honestly mean that, because I think that, there are certain things that we can do from a medication perspective in terms of cognition and dealing with other things, but ultimately it's around providing that ongoing specialized kind of support, which is really the allied health kind of really. So prior to starting up the memory clinic a couple of years ago, I was still diagnosing a lot of people with dementia, but I just found that I then struggled to kind of know how to go forward with things. I don't have the skills of an OT or a physio or a care navigator, and so I felt a bit kind of helpless. Patients felt a bit helpless. And so I think having the ability to have allied health on hand and is just really, really a good thing.
Yeah, absolutely. And look, that does bring us to medication. I wanted to ask you, what are the common drugs that a doctor would prescribe to manage the symptoms of a dementia?
So when we're looking at trying to enhance cognition, so improving memory and so on, then most of the medications are predominantly used for Alzheimer's disease. That's where most of the evidence is. So the other forms of dementia, vascular dementia, although some people might benefit from these medications, they're not officially licensed for them and they don't work quite as well. So if somebody has what seems to be a severe vascular dementia, I wouldn't necessarily use these medications. But if certainly somebody has Alzheimer's and they don't have any reason not to go on the medications, and I'll mention that in a moment, then I would have a low threshold for trying these medications because some people find them quite helpful. The research sort of suggests that these medications, which are called cholinesterase inhibitors, they have modest effects. So they're not dramatic in terms of the improvement that people get on the medications. But having said that, I've seen a lot of people who report tangible benefits. So we start them and 3 to 6 months later, they're actually reporting that they feel considerably better, their memories are better, they just feel better in themselves. And so I've seen enough of the time to be keen to sort of try them if people are interested. And so what these medications do is they essentially oil the brain in a way. So between your nerve cells, you have these things called neurotransmitters, which are these chemical messengers, if you like, which relay messages from one nerve cell to the next. And in Alzheimer's disease, for various reasons, that the level of those neurotransmitters drops. And so you don't get some good connectivity between your nerve cells. And what the medications do is indirectly increase the level of that neurotransmitter, the acetylcholine, which basically means the whole network runs more smoothly. So these are not medications that cure Alzheimer's, but they are symptomatic treatments. So they can result in improved memory and so on. And there's 3 different licensed ones. And one of those actually comes in a patch form as well as a pill form. And so that's what we sort of tend to use if we can. There are certain conditions that mean we can't start them. So if you have significant problems with slow heart rates or heart block, or you've got active ulcer disease or very bad sort of asthma and bronchitis, they're a bit dangerous to use. And sometimes if somebody's really frail, we might be a little bit cautious about it as well, because they do sometimes have side effects of weight loss and so on. But ultimately, it's I guess just a judgment call, but ultimately if they're keen to start it and there's no major contraindications, then I have a low threshold for trialing these medications. The other thing I should say is that they're probably best used in the early stages as well. So the evidence suggests that that's where you're going to get the most benefit, which is another reason to actually try and see somebody early. If you're wavering about whether to sort of get a diagnosis and what's the point, then the definite point of it would be, well, if you do end up having Alzheimer's disease, then the medications we have that help best in those early phases. So that's definitely something to bear in mind. There is another medication called memantine, which works in a slightly different way, which we tend to use sometimes in conjunction with those medications or certainly later down the track. But those are mainly the medications that we use to help with memory and so on. And then often I would use medications for other reasons as well. So unfortunately, as part of dementia, often people can get things like depression and anxiety and sometimes other mental health changes, sometimes sleep disturbance and so on. And in some instances, it's appropriate to try medications to fix those things as well, to sort of essentially improve quality of life.
Are there any other strategies that you could recommend for people to maintain? And I know it is kind of, knowing your approach to work, I know you actually published a book about this, but are there some other strategies that people could consider to maintain cognitive function even after a diagnosis of dementia?
Yeah, so I'm an optimist about this. I think there has been a little bit of nihilism about some of this over the years, that once you have dementia, then all of these strategies that you might otherwise use are less helpful. And there probably is a sort of diminishing returns to a degree. However, we do have evidence to suggest that even in the early stages of dementia, certain things can be quite helpful at specifically improving cognition, or if not doing that, then improving quality of life. Probably the biggest thing of all, which my patients know I'm a broken record about this, but is exercise. So keeping physically active. So we know that exercise improves blood supply to the brain, which can only be a good thing. It helps with this thing called brain-derived neurotrophic factor, which is like a fertilizer for the brain and helps with neuronal health and maintenance and so on. And it can also help regulate sort of metabolic problems as well, exercise. So I'm a huge advocate of that. So even in the early stages of dementia, even in the moderate stages of dementia, to be quite honest, I'm very keen for people to get the sort of requisite exercise in their week. So 30 minutes of moderate exercise most days, some resistance training, so weights if they can, a bit of high intensity if they're safe to do that. and some work around balance as well, just to make sure that they're reducing the risk of fall. So exercise is a big thing. I think there is some evidence to talk about using your brain still in the early stages. And so what we call sort of, I guess, complex mental activity. And one of the things we offer in our clinic is this thing called cognitive remediation, which is a process really where you sit down with a neuropsychologist, or our OT does Laura does a program called Memo Rehab that she might talk to you about, I suppose, when you see that.
Yeah.
But that really is all aimed at looking at your strengths and weaknesses when it comes to cognition, and finding strategies and skills and techniques to best use your brain to navigate day-to-day function. And there's some evidence to suggest that cognitive remediation actually reduces the rate of decline cognitively as well. So that's the other thing that I'm keen on. There's a lot to be said around socialization and staying in touch with people. I think loneliness is a huge problem, across the whole lifespan, particularly maybe an issue for people that are a little bit older because of friends passing away and adults living home and so on. So it is a real concern, and we know that socializing is good for your brain, it's good for your mental health. It actually gives your brain a good workout, the twos and pros of conversation and so on. So that's probably the other big thing as well. But yeah, I think a lot of the strategies that we would talk about to prevent dementia in the first place, there's no harm in doing any of them in the early stages of dementia, and they may well be helpful. Hearing, that's the other big thing. Often people's hearing is a real problem as you get older, and that can sometimes give a false impression actually of how bad someone's cognition is. Are they being forgetful and repetitive because they can't hear you, or it's just harder for them to process what you're saying to them? So correcting hearing loss is another big thing as well. Making sure that you're prioritizing your sleep, because sleep deprivation is a real problem in terms of brain function, and managing stress. So that's the other thing. So whether that's lifestyle changes or speaking with a psychologist or even medications in some case. Often I've seen people who are in they seem to be in the sort of moderate stages of dementia, and they're also very anxious, and we treat their anxiety and they'll have dementia, but they seem to be much earlier in the journey because actually the anxiety is given the impression that they're a lot worse than they really are. The anxiety paralyzes our brain, and our memory's not so good, we can't problem solve, etc.
That's just wonderful, Kailas. I love that you bring that optimism, and quality of life factor to approaching a person's care, because a lot of people still look at a diagnosis of dementia as just, it's just being such a catastrophic thing, and it is terrible, but it's, it is still possible to retain that quality of life and have meaning and have purpose and joy, and a good life and an ongoing good life after a diagnosis.
Yeah, absolutely. And I often say this to people that say, just because I've now said that you have Alzheimer's disease or so, it doesn't fundamentally change you as a person.
No.
Nothing changes. You just need to kind of put in provisions for what, may happen as time goes on, many of which would be relevant if you have dementia or not, just as you get older.
Yeah.
So it doesn't fundamentally change you as a person. And people's experience with dementia is highly variable. And I've seen people who are 10, 15 years down the track after a diagnosis, and they're still doing okay. They've got reasonable quality of life and so on. So that's really the message that I try and get across to people.
Wonderful. As you've heard Kailas explain, listeners, the pathway to diagnosing dementia takes a little bit of time, and other conditions that look like a dementia need to be excluded. Supporting the person and their family at diagnosis and as the disease progresses is key to remaining well and able. We have Kailas's details in the show notes if you want to follow up with his clinic, and we also have the link to his book, Mind Your Brain, which I might add is an excellent resource and worth the time taken to read. Kailas, thank you for joining us today. Until next week, listeners, here's to your good brain health.
Hey Care community, thanks for listening to this episode. So you never miss a show, make sure you subscribe to our podcast. If you'd like to know more about what we do, head to our website, cmeacn.com.au.